At, we have a NHMRC Centre of Research Excellence in TB control, and we've been fortunate to actually have two of these, and we're about halfway through the current one, which started in 2018. And as Ellen knows, we were able to have our symposium in May when things were quieter and link around the country. So we had a session on COVID and I gave this talk, which I've subsequently updated because there have been further developments. Let me just see now. Right, so I want to quickly cover 5 things, and I have got about half an hour, if that's okay. Is that okay, Ellen? Yeah. I can't hear you, so I assume you can hear me. Is that correct?
Yes, I'd muted. Sorry, that's about correct, and we can see how we go with questions at the end.
So we'll have a comparison of SARS-CoV-2 and TB, MTB. We'll talk about the impact of current TB on the clinical course of COVID, then the impact of COVID on the course of active TB, the impact on control programs with a couple of recent publications and reviews on this, and then some thoughts on what we can learn from COVID for TB control. Firstly, okay, so you know that we're out here on the right-hand side of my screen, which I think is your left-hand side, with SARS-CoV-2. But we actually have had, and we've all been infected with seasonal coronaviruses, of which there are 2 kinds, alpha and beta. And these have been well documented since the 1960s and are a common cause of cold, but no serious respiratory illness. Then in in the first SARS, which was in 2002 to 2003, then MERS in 2012, and now the current pandemic. So we're not going to have a discussion about where SARS actually came from at the moment, probably from an animal model, from an animal infection in most likely in bats, possibly transmitted through an intermediate animal or humans who had been infected and then moved to Wuhan. My one personal talk is that we were in Wuhan on November the 6th to the 8th, 2019, when we held a symposium in China on the immunology of tuberculosis. We've been holding these for about 5 years. This was our 5th and the first in Wuhan. I then caught the train down to Shenzhen with my colleague. But interestingly, that was probably a week before there was transmission of SARS-CoV-2. It's an RNA virus spread by aerosol and droplet. And really, the impact in terms of clinical disease also targets vulnerable populations. And this compares with TB, which we know has been coexisting with humans for tens of thousands of years. In fact, we actually think TB in cattle came from TB in humans rather than the other way around. Also transmitted by aerosol, affects vulnerable populations. And both of these pathogens, unfortunately, are here to stay. In the case of TB, we have a vaccine that works in children, but is less effective in adults. In the case of COVID, we have vaccines, whether they're the last vaccines we'll be using remains to be seen. So the epidemiology of COVID was really pretty well defined last year, prior to Delta, where you had an incubation period over some days. And this major difference to influenza is there's an infectious period for a number of days before the person becomes symptomatic. And then it can spread relatively widely with a reproduction number of RO of 2 to 3. And the transmission is particularly indoors in household contacts, workplaces, and as we are unfortunately experiencing in Sydney at the moment, also in health facilities and aged care facilities. And if I was giving this talk 6 months ago, droplets would have been above aerosol. But now, and I'll give you a reference at the end of a very recent paper, which summarises the evidence that aerosols are probably the major means of distribution. However, we need all of this, of what we think we know about this condition is based on the original Wuhan strain, although we don't use that term now, but then subsequently the alpha, beta, and gamma strains, and now delta. And delta has risen at such a rate that it has become the dominant global strain. As we discussed, there's an incubation period, and this is where the differences to TB become so evident, that the prolonged incubation period of TB into adulthood, but even in children who get TB, the incubation period is over months, whereas with this condition, it occurs rapidly. I just added this slide to just highlight the fact that although we think and certainly involved in respiratory control of infections, that the pulmonary manifestations are the most important, with a fever and a cough, the development of atypical pneumonia, and then respiratory distress syndrome. And this process actually takes 10 to 14 days, leading to multi-organ failure. However, increasingly we recognise now that COVID-19 disease is not just a respiratory pathogen or a respiratory virus in the typical sense, but you get involvement of the endothelium and blood vessels, and this may contribute to the increased thrombosis that we see, the hyperinflammatory syndrome and the hypercoagulable syndrome. And all three of these come together, manifesting as kidney damage, certainly venous thrombosis, pulmonary embolism, stroke, and a marked difference to normal viral-induced ARDS is prolonged ICU admissions of up to 3 to 4 weeks. Now, COVID is also differs that of the marked age propensity for outcome. And this data, which was from the middle of last year, just shows how the mortality rate from this condition dramatically goes up after the age of 40. And now this has been reproduced in multiple countries around the world. Itself, in contrast to TB, we now know these are the predictors for severe COVID. Age, over the age of 40. Male, a slight but definite preponderance of increased mortality. Diabetes, in particular, has consistently been shown to have increased outcomes. And this is actually relevant to tuberculosis, as we'll discuss in a few moments. Other forms of chronic lung disease and heart disease, but there is also this significant effect of lower socioeconomic groups. And this is evident in many countries around the world. In the United Kingdom, in doctors, for example, the mortality rate in doctors, and there have been well over 40 medical practitioners have died in the UK. This is much higher in those from an Asian or Caribbean background, even though socioeconomically they would be identical with other people. And in the United States, this is also evident, although, of course, it interacts with socioeconomic effects. So ethnicity probably does have an effect on poor outcomes, and the basis for that we don't know. So you probably knew all of that, and the question is now, what is the effect of TB? Is TB have an effect only because it occurs often with poor socioeconomic factors, or does TB itself contribute to poor outcomes? Well, this year there have been 2 studies which demonstrate that tuberculosis, active and past TB, are associated with a bad outcome. So this is a meta-analysis really only of 4 studies, and you can actually see one of these studies had 20,000 people and the others had 200 to 400. However, in this group of studies looking at the effect on mortality of tuberculosis, you can actually see there was an increased mortality with a risk ratio of 2.1 and with significance. However, I think and so there's no doubt that TB is associated with a poor outcome from COVID. However, I think really one of the strongest evidence for this is this study from Cape Town, where they took 15,000 cases of COVID-19 disease, and they were matched with health records and death registries. So this was done at the level of population. And you can see, and then looking at here for the adjusted hazard ratio for a number of conditions. You can see at the top, looking at the effect of gender, that in fact, males were associated with an increased risk of death. And here we can see in the South African population, as opposed to the earlier data, which I showed you, which was from China or from the United States, there's a dramatic increase. And unfortunately, we're seeing this in Sydney at the moment. Diabetes also has an effect. And in this case, that because they had the medical records, they were able to stratify diabetes also on the basis of the hemoglobin A1C. And you can see that there is a tendency for diabetes, which is less well controlled, to be associated with worse outcomes. Looking at other communicable diseases in this population, hypertension was not a factor, but chronic kidney disease was. And I think this was underestimated in some of the early studies. But chronic renal disease, and we now know that dialysis patients in particular infected with COVID will have a worse outcome. But we're interested in TB. And so, of course, in Cape Town, there is a large amount of tuberculosis, unfortunately. And here you can see either current tuberculosis or previous tuberculosis was associated with a worse outcome, with odds ratios of 1.5 and 2.7 respectively. And HIV positivity was also associated with a worse outcome. So what is the mechanism of this? Why do people with tuberculosis do worse? Well, the first factor is obviously TB, and particularly TB where there is delay in diagnosis or inadequate treatment is associated with progressive lung damage, loss of lung function. So reduced respiratory reserve is one factor. And not all forms of chronic lung disease, and in fact this study from Lancet Respiratory Disease in April of this year showed that, for example, chronic obstructive lung disease and interstitial lung disease, but not asthma, were associated with worse outcomes with COVID. So pre-existing respiratory disease is associated with severe COVID. However, there are other factors which may come into play. You will know that the SARS-CoV-2 virus binds to the human acetylcholine esterase, or ACE2 receptor. The ACE2 receptor, which historically was associated with the kidneys and control of blood pressure, is in fact distributed in the lung and in the gut. But it is more in healthy people, it is expressed in the upper airways, in the nose and upper airways. And normally in the lung, there are very low levels of expression. One of the factors that increases the expression of ACE2 in the lower lung is smoking. So the chronic inflammatory effect of smoking leads to increased ACE2 expression, and therefore the potential for more rapid progression from COVID. And TB leads to chronic inflammation in the lungs, and there is increased ACE2 expression in the lower respiratory passages. In addition, the increased systemic cytokine response may be exacerbated because of the pro-inflammatory nature of TB. So TB makes COVID worse. This is a study from the Philippines, which I think really highlights this. Here they looked at a cohort, a large group of patients who were being managed in the community and in hospital. So on your right is the full cohort of patients. On left, it was those who were admitted. And at the top, we have the potential for death. And you can see in red, those who had TB compared, those who did not have TB in red compared to those who had TB, that the mortality rate increased in those with TB. And this occurred both in outpatients and in admitted patients. If you looked at the other way round, the top looks at the time to death, the bottom looks to time to recovery. And you can actually see that TB patients in green or green-blue had a longer period of time to recovery. And this was really quite significant. So TB is associated with increased risk of death and a slower recovery from COVID infection. Now, let's think about it the other way. What would be the impact of COVID on TB? And one can think about this both active tuberculosis, but also latent TB infection. Now, it is difficult to determine this because we know, probably less from our experience in Australia, from what we know is happening with colleagues overseas, that one of the effects of COVID was to reduce TB services, leading to interrupted therapy, delayed diagnosis, and I'll present some data on that in a few moments. And all of this could contribute to increased transmission. So TB may be getting worse during the COVID pandemic, unrelated to any direct effect of COVID on TB. However, we know that moderate and severe COVID disease is associated with reduced CD4 and CD8 T cells and immune dysregulation. CD4 T cells, we know from the HIV epidemic, are absolutely essential for the control of TB. So lymphopenia occurs, and that's shown down here in the slides. In red represents COVID patients, and you can actually see, compared to green or healthy individuals, their total T cells, their CD4 T cells, and their CD8 T cells are reduced. However, this does recover at relatively quickly in the case of CD4 T cells, but you can see the CD8 T cells are still significantly reduced. So does that lymphopenia increase the risk of reactivation of TB? And for the moment, we don't know. But in environments where this is severe at a population level may have an effect. Now, a group in Cape Town, led by Rob Wilkinson, have tried to look at this in a more detailed way. So they've looked at the relationship between SARS-CoV-2 T cell responses and the impact of HIV and TB. So basically they had groups of subjects who were healthy or who were in hospital but without TB, HIV or COVID. They had people with COVID at the different WHO gradings for the severity of COVID. They had subjects who were HIV positive and subjects who had active TB. And they examined their responses to TB and COVID the way we do an IGRA assay, whole blood assay, where instead of adding the TB antigens, and they use DSAT6 and TB 10.4, as we do in IGRA assays, they also did an IGRA assay for SARS using SARS peptides. And basically what they showed is that there was a reduction in the TB-specific T cells in people with SARS. And this is summarized here on the left-hand side of the screen. The SARS-CoV-2 specific T cells were present actually in control subjects as well as COVID patients. And you'll remember that I said that we've all been infected by seasonal coronaviruses. And we actually have a background response to SARS-CoV-2 due to our T cell response to the seasonal coronaviruses. Unfortunately, it doesn't protect us. The patients with COVID had T cell responses. They were poorly functional, and these were reduced in the subjects who had HIV and TB. But we're interested in what happened to the TB-specific T cells. And in fact, there was a reduction. So COVID was associated with a fall in the total CD4 T cells, but also a reduction in the frequency of TB-specific T cells. Does this mean these subjects will reactivate their TB? We don't know. But there are ongoing studies, I know, on this in high TB burden areas. And this is just to show that here in the green, we're looking at people with COVID and showing that there is a reduction in their total number of MTB-specific T cells. And these were even lower in those who had HIV infection. So COVID is associated with reduced specific T cell responses to TB, and the rate at which these recover is not known. Okay, so I'd like in the remaining time just to talk about what are the big picture factors during the COVID epidemic on TB. Early in the course last year, the Stop TB Partnership did a modelling analysis of all these different factors and the balance of those which could influence TB. And they projected that there would be an increase of 5 to 15%. Now, what happened, and this was about June last year, what happened? They predicted there would be a rise in the incidence of TB, but as the services were restored, that this would fall. And you can see here they estimated either a 2-month lockdown or a 3-month lockdown. and with comparable effects on mortality. Unfortunately, they didn't predict the wave of Delta virus, which has swept through India and Nepal, where I have particular colleagues where this has had a major effect. So this is looking at what happened in 2020, leaving aside what's happened this year. And you can see that these figures, which are from WHO, that there was a fall of about 1.4 million new TB cases, particularly in high burden countries, compared to the 2019 average. So this reflects TB notifications. It obviously doesn't reflect the incidence. And down the bottom, you can see that it varied in different countries. In South Africa, it fell quite dramatically, but by June, it had recovered. But again, at the end of last year, as the South African variant emerged, there was a fall in notifications, whereas this fall persisted in India. And this had different effects in different countries. This is looking in Spain and just highlighting this fact that amongst those who were the children of people with active tuberculosis, there was an increase in both active TB in 2020 in childhood contacts and the development of tuberculin positivity. So there was an increase in both active and latent TB, and there was a trend for the tuberculosis to be worse on radiological scoring. Now, for those in Melbourne, you will be aware of this study because a group of people, including Justin Denham and Jan Willem Alphenaar in Sydney, were part of this study, which had largely European participants, but 19 countries, 5 continents, 43 TB centres, to compare the effects over the full year of 2020 and using a standardised reporting. And these are the countries involved, although I would say in India there was only one clinic in Mumbai, which, as we know, is certainly not representative of India, and the vast majority of Asia, Indonesia, PNG, and Africa were not involved. But this did provide quite accurate reporting for these centres. And you can see here, and this is from the research letter that's in the European Journal of Respiratory Disease, that in 2019 is blue, 2020 is red. So there was a reduction in TB notifications or TB disease everywhere except Australia, Singapore, and the clinic in Virginia, which reported their findings. So in Australia, we've been able to avoid this underdiagnosis of TB. Obviously, tuberculosis didn't miraculously disappear in 2020. It just wasn't diagnosed. And you can see there was a reduction in TB discharge from hospital. Particularly worrying, and this has been reproduced elsewhere, there was really a dramatic fall in the amount of testing being done for drug resistance, and which was down to 30%, suggesting, in fact, probably indicating that drug-resistant TB in many countries of the world is not being diagnosed and will represent an ongoing problem. In the case of TB deaths, there was also some reduction, but that probably there are many reporting factors about that. In the other factors they looked at, there was a reduction in TB, newly diagnosed TB disease in clinic, TB infection in the clinics, latent TB diagnosis. And the one thing which did go up was the use of telehealth for TB disease. And I'm sure everybody online has become experienced in telehealth for following up patients. As well as this study, there's a very recent study published in the International Journal of TB and Lung Disease, where the London group, the London School of Hygiene and Tropical Medicine, did a review, a systematic review as much as it could be, on country by country. So they collected data from a large number of countries, and they looked at TB services, TB vulnerability, and outcomes. So firstly, looking at TB diagnosis, and there was a general reduction in TB diagnosis around the world, and the latest figures are from WHO and the Global Fund, which showed 20 to 30% fewer TB notifications. There's a 45% reduction in testing for MDR-TB and a reduction in number of TB tests. Interestingly, in South Africa, the proportion of TB tests that were positive has gone up, which suggests that only people with very typical TB symptoms are being tested, and there's a large number of undiagnosed TB cases in the community. In terms of TB treatment, we need a longer time frame to identify the impact, but it was estimated that there was a 5 to 15% reduction in treatment outcomes. And although lots of effort has been made to use digital technologies, we don't know their impact. Even more worrying was the effect on TB prevention, and that there was a 30 to 70% reduction in preventive therapy enrolment. And although that's recovered in some countries, in many it hasn't. And of concern is that the BCG vaccine coverage in infants has decreased by up to 60%. And the best data was from India and Pakistan, which of course are very large countries. And this has potential consequences for child TB mortality in those regions. They also looked at the vulnerability to TB and what is the effect of a decrease in healthcare provision. And for example, if you have reduced control of HIV and diabetes, that will increase vulnerability to TB. What is really worrying, and I'm aware of this because of the impact not only on TB but leprosy control programs, there is an increase in poverty because unfortunately many TB and even more so leprosy patients are part of the grey or black economy. They don't have regular jobs, they're just day labourers, and they immediately lose their employment, resulting increase in risk of catastrophic costs, increased crowding, and increased malnutrition, which is still the biggest single risk factor for TB globally, increase in malnutrition. We don't really know yet exactly what the effects have been on the transmission of TB. It could be in the community, the use of masks and spacing will lead to reduced respiratory contacts in the community. And we see that obviously in Australia with influenza, but is that happening worldwide? On the other hand, in households, there could be increased crowding and contact in households, increased transmission if there is delay in diagnosis and treatment. And of course, there could be increase in vulnerabilities. And this will vary greatly from country to country. It's difficult to measure on our routine data, but all kinds of, the use of mobility data, the use of measurements of mask wearing, what will be the effects of this on TB in the long term? And this paper in the International Journal of TB and Lung Disease finishes with this rallying call to really do more detailed studies to fill the priority gaps, to know what's happening in diagnosis and treatment, patient vulnerabilities, effect of COVID on diabetes and HIV, and what is really, in the long run, the effect on transmission. So just to finish, two last points. There's certainly lessons from COVID-19 that we can learn for TB research. I think the overriding importance of data in infection control and the quality of data in informing policy decisions. There are two factors in that. You've got to have the data and you've got to have people who will respond to the policy decisions. For many years in TB control in high burden countries, we've had evidence of disease but not had a comparable response from politicians and those who control the health budgets to invest in TB control. We've learnt that resources rapidly applied can make a big difference. We've learned a lot about the molecular epidemiology of transmission. I never thought we would have discussions about genotypes of viruses in the evening news. Everyone now knows that you can trace individual strains of virus and TB. PCR is now part of the modern vernacular. Have you had your PCR swab today? For someone who's spent 25 years working on TB vaccines, the amount of resource that's gone into COVID vaccine, if we had a tenth of that, we could do a lot for TB. However, the downside of all of the new vaccines is there's an abundance of vaccine experts, not all of whom are expert. Repurposing drugs, new drug development, rapid clinical trials, particularly adaptive clinical trials, understanding transmission dynamics, not just on genotypes of viruses, but what people do, how people behave. And a final point, which has often been not recognised in high burden countries, the importance of infection control in healthcare settings. And there really is significant transmission of TB and unfortunately MDR TB to healthcare workers in high burden countries. And we really should prevent that. But I would also say there are lessons for COVID from TB control and expertise. And I know many of the people listening would have been called into the COVID response in their various parts of Australia. And I think with the effectiveness of our TB control in Australia and maintaining TB control during the epidemic is really a tribute to the work that all of you do. Just finally, I would draw your attention to this paper, which has just very recently been published in August the 27th in Science. It is a detailed review on all of the evidence for airborne transmission of viruses. There is actually also a one-page summary at the start, which is very easily accessible, and I believe it's under open access. And it's about the evidence for transmission by aerosol of viruses, in particular SARS-CoV-2, and the various factors which have been underestimated in the spread of viruses by aerosol. And it actually goes into, in the main paper, it goes into some lengths to show that it's not just a simple case of things less than 5 microns get into your lungs and everything else falls on the floor. There is a marked gradation, and aerosols can persist in the environment for some time. I won't go into the details of that, but the final picture in this paper is about factors which influence airborne transmission, not only of viruses, but also of other respiratory pathogens. And I think it would be very good to have a look at this, because it describes the factors responsible for distributing aerosols indoors, the fact that they do rise, airflow patterns matter, ventilation matters, and air filtration to an extent matters. Although I think the safest place to have a TB clinic in a high burden country is outside, not in the clinic, not an enclosed space, but underneath a tree. So with that, I'll finish. And I think for those of you interested in infection control and TB, I'd encourage you to look up this paper. And certainly the first page summary is very, very accessible. Okay, thanks, Ellen. And I apologise that my computer was not set up. Just shows you an academic with a Mac. But I'm now set up for all team meetings in the future.
Thanks, thanks, Warwick, so much. I think it's just, I mean, the things I sort of take is it's interesting because obviously TB is not going down in Australia, despite in effect closing the borders. I guess it's not surprised that gene expert machines have been repurposed for COVID use, which I'm suspecting is what potentially explains the significant reduction in drug susceptibility testing that was going on. And I mean, I think the take-home message I think that we discussed earlier in May, June was that the key here is that vaccines for COVID should be really highly recommended for TB patients. I mean, obviously everyone, but that, you know, there is really significant effects on mortality and duration of or length of time to recovery for patients with current or previous TB disease. I'm mindful that it's 3 o'clock. Warwick, do you have time to stay if there is a few questions?
Yes, I can for a while.
Yep, and obviously if you need to leave, thank you very much for joining, and we'll have recorded any questions. So does anyone have any questions for Warwick? Wow, silence. Must mean you explained it very well, Warwick.
No. Okay.
Can I just, I guess, can I ask, is there any other, it sounds like the infection control things, and it's something I haven't looked into in a great deal of detail yet, for COVID have been possibly better described than what I've seen for TB. Do you think that that's the case? Is it that we just don't have that kind of level of sophisticated information? I'm guessing it's probably harder to research.
I'm aware of this because of colleagues in Cape Town. In fact, Gerhard Wasel, who's at Stellenbosch and a prominent TB researcher, his daughter was doing medicine, and a number of the medical students had developed MDR-TB. And for those of you who've been involved in any of the TB union conferences, one of the students who developed MDR-TB and was fortunately was treated, actually has become a full-time TB advocate. And this was everybody knew that it happened, it knew that staff got TB, but it was kind of hidden and thought that, well, there's nothing you can do about it. And it does raise the issues of just appropriate. Now, I think this happens in the Australian context, not always optimally, because we all know there is a shortage of negatively ventilated rooms. I'm not quite sure where in the hospital situation where you are, but overall, there is a shortage of negative ventilated rooms, and which means that you have to go to other measures. I think this is a huge thing in high burden countries. And I've worked in Nepal for 7 years in the 1970s and 80s, where the concept of wearing a mask in a busy outpatients would have been something you would have just not contemplated. But in fact, the 100-bed hospital where I worked had 1,250 new TB cases a year, which is about what we get in Australia. So, and we used to see about 250 new cases of leprosy. And actually, after I left the hospital, I learnt that our leprosy worker in the hospital also eventually developed leprosy. So these are respiratory pathogens, and staff are at risk. Okay.
Just one other question. How long do you think, so the data you showed on the reduction in DST was for cases, I seem to recall. So one would assume that they're just being treated with for drug susceptible disease, and so therefore may fail treatment for that. How long or how much effect do you think that could have in the future? Like, do you think it will have a significant impact on MDR rates worldwide, or
It probably, well, I think it'll be great, really dependent on the background rate of MDR in that community, won't it? So in a place like Vietnam, where it's not that much above the world average of 3.5 to 4%, right, it could have an effect in 1 in 20 patients. And so that may not be a huge effect. But in places where the MDR rate is much higher, yes, it could lead to a real bounce again of MDR TB. So in a number of MDR TB hasn't gone away, but it's actually been held in place a bit in a number of countries. But for example, in Papua New Guinea at the moment, with the spread of the Delta variant and high background rates of MDR TB, people talk about it putting back TB control 5 years at least, and possibly more. And so that's very disappointing. It increases our need to be strong advocates for TB.
Fabulous. Okay. Did anyone have any additional questions?
Okay. Well, listen, maybe another occasion.
Well, I think on behalf of the network anyway, Warwick, I'd like to thank you for that, because I think it's pretty important to keep on top of, I guess, the new emergent evidence on the interaction between the two conditions and how it might affect our TB patients. So thanks very much. And if anyone does have any questions, I'm sure if you reach out to me, I can ask Warwick.
Okay.
All right. Thanks very much. And
Thank
thanks
you
to everyone for joining.
Thank you, Peter, for setting up my computer for future 2 meetings. I have one.